Hi, everyone. Welcome back to another Early Stage Researchers career series. And today we have Anna Ostropolets. She's the Director and Head of Innovation, head of the Innovation Lab at Odysseus Data Services. And Anna's going to talk to us about her career. As a brief description, she has more than 7 years of experience analyzing observational health data with full stack from data harmonization and ontology engineering to evidence generation clinical decision support. She has an MD and a PhD, and she's an active collaborator of the Odyssey vocabulary team from its inception. She's currently leading the vocabularies process, and her recent interests include bias adjustment in phenotyping and evidence generalizability, as well as point of care evidence generation. So thank you for joining us, Anna.
Thanks so much for inviting.
So can you maybe start out by talking about how you first got into health research, like how you even thought that you ever wanted to do medicine, because you studied internal medicine from Kharkiv National University. So can you talk about what even got you interested on this route in the first place?
That's a great question. I mean, I see a lot of people, especially in the US, that sort of changed their trajectories and get into medicine later on in their lives. That definitely was not the case for me, because I pretty much knew I wanted to be a doctor from like, I don't know, grade 2 or something. And it's always been a passion, you know.
Okay.
Started as biology and then it transformed into medicine, but I pretty much always knew that I wanted to be a doctor. And people say a lot about their passions in terms of like helping people and finding the meaning of their lives in helping people. I think, you know, besides that, it was mostly just the interest in how human body works and what we can do with it and how we can help people live better lives. But in general, it's always been the case. And research was a key component in our education if you want to get better grades, which was also important in our university. Also because the way it is structured in Ukraine is that you get your medical education, and then if it was free, if it was paid by the government, you have to then go back to a certain area that they tell you to go to, sort of underserved areas, and work there for a couple of years. And this is how, you know, you pay back for the money that they spend on your education. And in that process, getting research was something quite important because it partially determined where you would go at the end of your med school. So, you know, bottom line is that the research started as something that you gotta do as opposed to something you're passionate about. And I never really thought of myself as a proper researcher up until I got into Columbia, where I really felt that, you know, we were producing something that can be actually used for healthcare and something that can be quite useful and can be considered a real research, so to speak.
And I know you defended your dissertation recently, but your research has been like very intertwined with Odyssey. So like I know you've done biomedical informatics from Columbia, but when did your Odyssey journey start? Was that just sort of a byproduct of being at Columbia and therefore you kind of hopped into the community as well? Or can you talk about that?
Yeah, absolutely. It actually was quite the opposite. I got into Columbia because I knew they were doing Odyssey related stuff. And my work with Odyssey started, I want to say in 2016, with the vocabulary group. And back then, or vocabulary team. And back then it was just 3 of us being the vocabulary team. So we sort of started there. And back in the days, it was quite a small endeavor because of the number of people, and also because Odyssey was not that mature back in the days.
Mm-hmm.
And we started with something quite simple, such as mapping ICD-10 to SNOMED.
Okay.
So you know whom to blame if you find errors, at least partially, right? And yeah, it started as as work, and then it
Mm-hmm.
transformed into more research-oriented work in Colombia. But the the initial the initial push was from the involvement with the vocabulary team for sure.
Okay. So you're really one of the original collaborators, just right from the start.
It sounds pretentious, but sort of, yeah.
Yeah.
No, it was
And
quite fun.
and then since then, can you talk about how you've seen vocabulary and Odyssey change over time? What has the evolution been like since the start? And yeah, can you talk about that as Odyssey has grown over time?
You think, it's quite amazing in general how Odyssey has evolved since those days. Because if you think about it, that sort of touches on every aspect of the community, not only vocabularies. Because it started as something small where we had maybe tens of collaborators, right? As far as
Mhm.
I remember, of course. And then it naturally evolved into quite a large community where, we pretty much cover almost all of the continents, if not all of the continents.
Yeah.
And that's pretty amazing to see how it grew and how something that was quite small evolved into a complex system where, for example, now you have the proper collaborations on the methods and tools, especially after pandemic when we all got together in teams. You pretty much see the community where you can be involved on the daily basis. So every day
Mhm.
there's something you can go to. There are packages you can contribute to. There are all sorts of external meetings where we collaborate with FDA or EMA. Now with Darwin, it grew even bigger, right? So uh, it's not only the growing numbers, but also I think that the principles behind Odyssey evolved nicely into a proper collaboration, where
Mhm.
you can see different perspectives from different stakeholders. And this is something that is very unique because we have academic institutions, we have pharma companies, we have tech, we have regulatory bodies. And I think the scope of the collaboration is something that is quite unique in Odyssey specifically. And that pretty much means that whenever somebody comes, there's always something interesting that you can work on regardless of what your background is and what your primary interest in is, you know. And I'm sure you
And I
felt that
think,
as well.
yeah, I think one thing that also makes you sort of stand apart is that you're a clinical researcher, like you have that clinical background. How has that been helpful? Because it seems like you started out just with medicine and then went into research, and maybe now are you more skewed towards doing more research, but does that clinical background play a role,
Yeah,
or
no,
what, to what extent?
absolutely, of
Mhm.
course. Um, yeah, so the disclaimer here, yeah, let me, uh, the disclaimer here is that you do not necessarily need to be a clinician to do this work. What you need to have probably for any type of research or any type of work you do in Odyssey is somebody who has the clinical experience, right? And it
Okay.
just so happened that I had both the technical abilities and the clinical background. And one of the examples where I would say classical examples where it really helped is in our project, my early project in my PhD, where we built the data consult service. which pretty much was the service that takes clinicians' questions at the point of care. We'll look at the data at Columbia and also other claims data sources. We try to find the patients people are interested in, and then we're basically trying to answer their questions, which can be simple characterization study or incidence rates or comparative effectiveness, what have you, depends on the question. But one of the crucial elements that I felt was one of the elements that I felt was quite crucial or important is that when we get the questions, which in our case was done proactively, which means that we went to their rounds, we shadowed them, we talked to them extensively, and having clinical experience was quite useful there. First, because it's much easier to understand what they're talking about, even though I do not necessarily have a huge experience with all of the questions that they had, but still I sort of had this baseline understanding of what they were talking about, which is quite important. And the second point, which I do think is useful to think for people who would want to implement a similar service or who would like to do similar work, is that when you work with clinicians, it's natural that if they know that you have a clinical experience, they will trust your expertise more. And that, of course, makes sense. But also, this is something deeply inherited, I think, in the way medicine is practiced, simply because it's such a conservative field. Even though we try to innovate it, it's still quite conservative field. So having somebody who A, has the degree and B, has an ability to speak their language is very important in those initial stages of any service that delivers the evidence back to clinicians. And if you think about Stanford experience with what they call Green Button, which essentially is the data consult service as well, is that they had a whole team. They had a team of clinicians. They had multiple data analysts slash data scientists, and together they basically were trying to produce the answers that I basically was responsible for myself at Columbia. And that was only possible because I had both of the elements. So that I think is a classical example where clinical background really helps. But of course, if you think about the large scale studies or network studies, you do not necessarily need to have this experience because you know that there will be a clinician in the team, if that makes sense.
Yeah, I think what you said was so fascinating about how sometimes a clinician is just trusted more because individuals know that they have that expertise and background. A lot of individuals in Odyssey are not clinicians, right? A lot of them are maybe just researchers or in data analytics or industry. How do you think that when there's a group of so many different expertise, like people from on different skill levels and different backgrounds, how do you bridge all of that to make a coherent team? Because not all of them have like a medical background.
That's a really great question. What comes to my mind is this SOS challenge that is happening right now, right? And it's a terrific example of how you can take your real study and showcase it in the way that it can serve as for educational purposes, right? So as Odyssey grew, we naturally have this problem of different skill sets, different levels, different perspectives, and having the educational materials is quite important in being able to get everybody on the same page, right? So I do not necessarily have the answer on how to create the best team, what I think is important is that there is a solid educational system so that if you want to learn, you'll be able to do so. And the Eden Academy, I think, has had an immense impact in this regard, because now we actually have the videos that you can go through, and you have some exams that you need to pass to show that you actually learned something. So having this element is quite important in making good teams. And I know that Paul has been working on that as well. So that's one thing. And also probably having, if you're a creative team, having somebody who is more experienced and has been in Odyssey for a while is also helpful, I guess. What do you think, Paul?
So I'm an informaticist, so it really is about team science. And so understanding the roles of a team and how we can partner between the technical and the clinical is really the fun of it for us, is where there's so much technology out there that we're not porting into healthcare that it really has to be tailored well before it can fit the behaviors and the workflow and the interactions of our highly specialized care delivery.
Yeah, I think Anna summed it up really well when she said that it's a challenge. It's a challenge, but it's also a very beautiful thing to have like a team of so many different experts. So really leveraging like it in the right way, I think, is the power of Odyssey.
That is true. I mean, the somehow sad part about it is that I see multiple institutions working, not necessarily in Odyssey, in general in biomedical informatics, multiple institutions working on the same problems and not necessarily collaborating. And as a result, you either produce two nice pieces that could have been much better if you worked together, or you sort of just reinvent the wheel. And I do not really know how to solve that. It's just I have this feeling that if we had better collaboration within the institutions, across these institutions, we could have produced something that is much more robust. And in this way, having Odyssey really helps, because we can come together and work on on the same problems, and we have forums, we have teams, we have all sorts of calls. It probably does not fully solve the problem, but we are getting closer towards that, I feel like. But this challenge still exists, for sure.
Yeah, so Anna, thank you so much for presenting here today. I actually wanted to follow up on your continuation of the work on the green button service. I think that's so exciting. I always look at the gap between evidence and practice, and I look at Odyssey longingly for how we can find ways to create value for that as part of clinical care. And I really would like I know of a couple ways today. There's the formal way where we publish and then it ends up in the clinical guideline after a lot of validation. I think that's actually the right way of doing things. But I also see a lot of other value for sharing with the physician what the outcomes have been for patients in their hospital in their own EHR, as a way of helping guide them at least instead of just looking at one patient's record at a time. And so I know you've done a tremendous amount of work on eligibility criteria evaluation at the point of care, but I was hoping to get a little bit more about your vision of where do we see the green button experiments going, because this is where I think is going to be fascinating as we start looking at the next generation of molecular tumor boards.
Absolutely. No, but I do agree that you can sort of think about these two pieces of work as being two sides of the same coin. Because on one hand, of course, you want to produce the evidence that will be disseminated through the guidelines to a broader community. But then at the same time, we have lots of questions that people need the answers to right here, right now, right? And the green button or data consult service is trying to bridge this gap. What I do think is important there, and is the next step for such a service, is trying to scale it up. Because what we saw with our experiments is that we pretty much, reached out to clinicians. We said, here's this is what we do. This is the examples of the questions that we can answer. Do you have something like that? Or when we shadowed them, we also sort of picked up the questions. And they do not necessarily always see this gap in their knowledge. And so do I, naturally, because, I sort of have the ideas about some things, and I'll be like, just let's go with it, or let's consult somebody. If they don't have a definitive answer, we just go with the best option possible. So one thing is trying to identify the best methods on how to help them identify those gaps in their knowledge. And maybe this is creating a library of the questions that such a service can answer, and just showcasing what type of questions we can respond, or maybe this is something different. And our ability to help them identify those gaps, and also our ability to showcase that our evidence is trustworthy, is something of a challenge. Because of course, they would trust your responses if those responses align with their baseline expectations. But if they do not, then they're maybe more likely to scrutinize what you produce. And being able to explain the methods and why they robust in a simple language is something we should work on more.
So it's funny because when I read the papers from Stanford and from Columbia, I have to confess, I was a little disappointed because I don't know, you have to coach me on this, because I felt like I agree that I want to teach the clinicians how to ask a research question, but I want to help them affect the management of their patients and see that this knowledge can help them in their decision-making process. And I felt like a lot of the time you get caught up, either as the latency of the asking of questions and answering it, or helping them frame the questions. But I still felt like, something, we weren't getting to the clinical questions that the physicians were asking. We were helping them form a research question that they could ask later on. And I wanted more than that. I wanted, is an interface missing? Maybe something like, clinical looking glass, where they can interact with the data and answer and ask questions quickly. But did I take away from that the wrong impression from those papers?
No, that's a brilliant comment. I think that green button for sure was caught up in all sorts of research questions, absolutely. And of course, that naturally evolved into this company that they created to try to basically tackle the research questions. When we started the data consult service, that basically was my intention to help clinical care. Like, I was not interested in generating yet more research questions, because with the research questions, you should go to Odyssey, do network studies, and push it to the guidelines. We were specifically aiming to answer clinical questions. And I think the breakdown was in the paper. I think it was closer to 80 to 20%, where 80 is a clinical care and 20 is the research questions. And so I felt that we did quite a good job there. Then when it comes to clinical questions, what is really interesting, I felt like, is that clinical questions that aim to really be used in the care right here, right now for the specific patient tend to be simple in nature, simple in methods. One of the good examples was this clinician. We were shadowing him, and he looked an infectious disease specialist. So he looked at the blood cultures of a patient with a heart disease, and he was like, "Oh, there is bacteria that I haven't seen before. Like, I don't know what that is. Can you check if the patients with this bacteria has developed any complications, or if this heart disease can be explained by this bacteria. So in fact, if there is any association between the bacteria and heart diseases, and if so, what was the treatment and the outcomes of those patients? And if you look at the literature, there were basically a couple of reports, individual patient reports about this bacteria, but not much evidence. So what we did is we went into the EHR, we retrieved all of the patients with this bacterial blood culture, and looked at their outcomes. And basically, well, the bottom line was that no, there was no connection between the bacteria and any serious outcomes. But that was a very nice example of the question that is actually meant to be used. And usually you can distinguish research and clinical questions pretty well, right?
Do you also think it's partly, I kind of also feel that partly is when I'm looking at the clinical side, they shouldn't trust the EHR data because we know it's noisy, which is why we built all these complex phenotypes that are robust. But the phenotype library is not like systemic or has coverage over all the diseases. And we haven't been able to bring the phenotype library into that clinical environment where we can say, well, here's how you really should think of type 2 diabetes. Here's how you really, if you really want to, get through some of the noise in the data, here's how you can help you start classifying or looking at your patients from a characterization. And right, I think data characterization is probably a great way of saying how many patients went on to have this, that, and this.
Yeah, absolutely. That was, which I didn't get to, but that actually was the second area of improvement for such a service, is building either phenotype libraries or something, or methods, more robust and scalable and faster methods for phenotyping. Because what I saw is that phenotyping, in fact, takes up for the most of the time you spend on the question, because you want to make sure that you're identifying the patients that you really want to identify. Now, disclaimer, I do not represent the ideas of the Odyssey, right? So they may have different ideas on this matter. But what I feel like is that when you're running network studies, there is a set of approaches you want to follow, right? You want to make sure that your phenotypes are generalizable to the network. You want to make sure that you evaluate them on all of the data sources and so on and so forth. There is this balance between generalizability and precision. When you work with one single data source and you have this time pressure, what you end up doing is you end up quickly iterating on the cohorts, exploring the data. Back in the time, cohort diagnostic did not exist, but it would have been a great asset. So basically somehow trying to quickly get a grasp of the patients you're missing and maybe false positives. So it's much more hands-on, iterative process that you need to perform fast. And ideally, these two sides will come together when you can do a large-scale, robust phenotypes quickly without a need to go into the data and review individual records. Or you come up with a way of robust profiling of patients.
Yeah, so I think one of the challenges, right, at the time you're trying to make clinical decisions is not a good time to be doing validation of phenotypes.
Yeah.
And so absolutely. That is right. And that's what we need to get over to build trust, is that they trust the phenotyping groupings that we've built out that can help them look for, those type for their patients and typical things that might be that they need to discuss with them. I do think, so there was a company a few years ago, I don't know how it came out of, I think, Mount Sinai Clinical Looking Glass, which basically was a visualization tool looking at your EHR data, looking at your outcomes that you can kind of look through and do a bit of an N of 1 experiment to kind of look for this patient and see where where would there be similarity within that EHR and what sort of things might be, things that might be coming downstream.
Yeah, I will touch on that because I think it's quite interesting. Before that, yeah, when you for example, when you think about evaluation, you also sometimes think about chart review, and this is something that is familiar to clinicians. So we thought that there should be some improvements in that area, and this is why one of the last pieces I started on in my PhD was the patient profiles. where you essentially try to take structured data, meaning codes, and organize them in the way that sort of mimics the chart review, but yet only presents the relevant pieces of information to a given phenotype, because we know that charts have high volume of data, so it's easy to get lost in the charts and miss some of the important elements or information. So with these patient profiles, it's basically dimensionality reduction, where you only present the relevant information, and then it's organization of the data according to the principles of clinical diagnosis, where you have, the history of disease, competing diagnosis, relevant procedures, relevant complications, and so on and so forth. So it would be nice to work on that more and have this tool available for researchers, which should also help in building trust, because then we can, as a part of phenotype evaluation, we can show it back to clinicians and they will be able to make sense of it, as opposed to some random numbers of PPV.
So one thing that could be useful, you're saying, is this could be really useful as a potentially a context-driven clinical history summarization for like the ED, where you can kind of get a list of their major problems, temporality, have like a hierarchical sunburst diagram by organ system, or they can kind of be like the problem medical record oriented view for someone to do a quick boot up on a complex patient's records.
Yeah, I think so. And it's got to be relevant to you given phenotype that you're evaluating, because of course we know that there are multiple tools that summarize the records, right? But they're tailored more to clinical care in terms of how you quickly glance over the history to make sure that you prescribed a screening test or a drug or what have you. And here it's pretty much similar. It's just it's tailored to a very specific task of phenotype validation, so to speak. But in general, yeah, it's some sort of summarization.
The other thing I would love to see with beyond summarization now, if we can get that kind of, is to be able to do atlasing, right? Compared to populations. Now that we have populations, we could then say, now that we have this coded, we could say these things are unusual for this patient at their age, at their gender, and other things that are of that are outside of different distributions.
Absolutely, yeah, absolutely. Well, that sounds very much like what we would like to work on. And again, that goes back to the previous comments of having something better when we work together. So if anybody has interest in that, I would absolutely love to collaborate. Then you mentioned about the visualizations that can be used by clinicians. And it's interesting if you think about it, because there are two perspectives. One perspective is that you give all the tools to clinicians so that they can use it when they think they need it, right? And that is nice, because that probably is placed right into this decision-making process so that they can actually use the information that they need at the right time, as opposed to having the team who provides the answers not necessarily at the right time. Maybe we were providing that too late. And this perspective, while it gives much more flexibility to a clinician, also requires more knowledge on their side. So they should be able to have some knowledge of statistics probably, or knowledge about causal inference, to be able to say, oh, this is the pattern, but probably it's not significant, or probably it's not, maybe it's due to chance, and therefore I should not use it in my decision making. Or they should be able to interpret what they see. So it is more flexible, but it places more pressure on a clinician, and then probably requires, for it to be scalable, it probably requires some educational programming yet again. And we went towards the path of providing the information and having the expertise on our side. But of course, there are multiple people who work on the visualizations and giving the tools to clinicians, for sure. And I'm not saying
So-
that our
Oh no.
Yeah, I'm not saying
Please
that
finish.
our way is the right way. It's just one way.
So I know you've talked a lot about barriers and challenges in this work, and also how people can contribute. Because this is the early stage researchers working group, what advice would you have to someone who's new in Odyssey, but who wants to get involved in this work? How can they reach their career goals while also being helpful to the community and learning as much as they can?
Well, I guess the first step was to identify your goals, right? Which is absolutely not a trivial task. And I think you've been doing a great job in terms of showcasing where people can go after their, whatever, the master's, PhD, other types of programs that they're enrolled in, and showcasing all of the possibilities so that somebody can make an informed decision. But I think it is actually the most important part is to figure out what you really want to do. And from this perspective, I think Odyssey provides you with all of the tools to test out different options, right? So you can, for example, join a study and be a researcher, and you can try data analytics, you can try data science, you can try to develop your tools and methods and see how that goes if you think you fit in a given with the given task. So it sort of provides you with a playground where you can test out your different skills and different interests. And then you can also try more, so to speak, managerial tasks. I would imagine if, for example, you start a working group, right? Then you can actually test out if you like organizing things, if you like managing, if you like sending the right links to people and creating very nice Notion documents that other people can use. So, all of the things that are more managerial than purely research. So I guess the advice is simply try different things when there is low pressure, and see what you really like. And from there, you have multiple people posting opportunities. You can come to the Odyssey Symposia and you can talk to people to see if there are openings. So it not only provides you the playground for testing your interests, but also later on, it actually provides you with the opportunities to connect to different stakeholders and see which path you would prefer and whether there are opportunities at a given time when you're ready to, take this next step in your career.
And if someone thinks that they are particularly interested in some of the tools that you're using, whether that's Phoebe, Keeper, or getting involved in the data consult service, or just vocabulary, do you think they should join the Odyssey vocabulary team, or what? How would you, or maybe they don't know how to use these tools, but they want to learn? What's a good way to go about that?
Yeah, that's a wonderful question. Wonderful question because again, I've been thinking a lot about education recently, especially when it comes to educational materials for vocabularies and documentation and stuff. And I do not necessarily feel that I have the right answer or the right solution to this problem. But essentially, if you're interested in the tools, I would think you would try to find some videos. And again, now we have them on YouTube, so you can actually check them out. Or you would go to forums and we'll try to see A, if there are some documentation or educational materials, and B, what is the contact person for that. And with the tools, what is really nice is that if you go on GitHub, you actually can see the package maintainers, for example, and you can get in touch with them. We have all of the working groups like Hades and stuff where you would want to go. Specifically with Phoebe, and this is why I said that I don't think I had the right answer for it, but I guess specifically with Phoebe, you would just go to me or to Patrick, With the keeper, the work is in progress. So we have the phenotyping working group. You can go there and have a discussion. With the vocabularies, it's the vocabulary working group and vocabulary team. And we do know that we need more documentation and we need a clear pipelines for people to get involved, which is something that we are working on. But in the meanwhile, of course, you would just go to the working group call led by Mick, or you would go and try to join the vocabulary team. Absolutely. I do think that we need to work more on, and we do have Book of Odyssey sort of that also slightly covers this gap, but because we have more and more information and tools and what have you, the challenge of making it easy for people to get involved, I think, is still a challenge. And if you have some perspectives of that on that, I will be happy to hear them out.
Well, I think one thing I always like to bring up and also ask, and I'd love to get your input on, is about mentors. Because I think having mentors is so important. Like, even for myself, I know so much of what I've been able to achieve is just from learning from people who were willing to help to teach me and take me as a student and, you know, welcome my novel perspective and then teach me everything that I could learn. So how have mentors been important to you, and how do you think that junior researchers in Odyssey should go about finding mentorship?
Yeah. Well, I've been tremendously lucky, right? Because I work with George and I work with Patrick, and they're both affiliated with Columbia. So I sort of, have already been in a very lucky position in the way that they actually provide the mentorship, the real mentorship, meaning that it's not only teaching you something, but also advising you on how you would think about the opportunities, how you would think about your personal growth. And this is something that is a feature of either their demeanor or, the way they operate, is that they're happy to give advice and they're happy to get involved with different people. So this is very nice. So I've been lucky with that. But of course, the mentorship is absolutely crucial. And if you haven't been lucky to find a mentor in your own institution, be it industry or academia, I would really feel that finding somebody in Odyssey would be very helpful. And then how you go about it, I mean, at Columbia, we have in grad schools, we have this initiatives spanning, I think, over half a year each year, something like this, where they open the call for the mentors, and then they open the call for the mentees, and then they match them one-to-one. And they actually outline the requirements for the mentors to get in, which is you gotta find at least, I think, 1 hour every week or every month to meet up with your mentee and have this hour dedicated to discussing whatever the mentee wants to discuss. So I think if you're, establishing this mentorship mentee program, is quite important to set up the expectations and have the continuous process, as opposed to, oh, we met, we talked, I did not necessarily have the questions, so let's meet, in 6 months. I don't think it works this way. I think having a continuous process is really beneficial. And also, we do not necessarily know what we want to ask to begin with, right? So having regular meetings would be really useful for the mentees. But of course, that's crucial, absolutely crucial.
Yeah, thank you. I think I'm going to open the floor to others if they want to ask questions as well. I know one more thing I did want to ask you, in case others don't have questions yet, is I'd love to hear what your vision is for, like, how would you like to see biomedical informatics in 10 to 12 years from now?
Oh, wow. Oh, wow. That's a good question.
10 to 12 years hurts my brain, Faiza. Can you like lower that to like 3 years or 5 years?
All right, how about 5 years?
No, that's I don't think it necessarily helps, right? I do well for the Odyssey, there are multiple things where we can go towards, and helping to introduce informatics into everyday care is absolutely one of them, and having more collaboration, meaningful collaboration with the regulatory bodies where they would actually use what we produce would be something we probably should work on more, as we are now, but of course there's much more to do in that regard. I do think in general, in not in biomedical informatics, but just in medical informatics, in 5 years, what I would really love to see is better perception of informatics and how it can change the healthcare, because we are working towards establishing trust, but we are not necessarily there with the individual clinicians, with the institutions, with the regulatory bodies yet again. So if in 5 years we can achieve better trust, that I think would lower the threshold for all of the innovations that we do and their practical use in healthcare. I think that would be one of the bigger items.
Yeah, that's so interesting. You're targeting not something very tangible, but something that's maybe harder to achieve.
No, that is true. But like, if you, for example, look at all of the AI development, right, for prediction or for other tasks, we've been talking now for a couple of years about trust in AI and how you can really trust the output. And this conversation is not over. And this is one of the major impediments in using more of the tools, right? So while it's not really tangible, but it's sort of a bigger item that I think would be really useful for us. I mean, the practical items is, having clinicians trust the observational data and using the evidence in their practice. This is more of a tangible item than this broad stroke.
Yeah.
Or maybe using ChatGPT to, answer all of our clinical questions or something. That also would be tangible outcome. Not the one that
did you have a question?
Mm-hmm.
Well, so I joined late. I missed the first half, but I assumed it was something about like data console, and then so I was actually just about to ask, like, hey, about ChatGPT, like, what kind of things do you think we can do or maybe not do with ChatGPT? If you want to, just to speak a little bit more. You kind of ended on.
Yeah, I'm not necessarily the expert in the large language models, but I know that multiple people have been trying to use that for all sorts of tasks, right? Be it short summarization or other things related to ontologies, which are in the very early stages. One of the things, that the language models do well is providing a description of complex ideas, right? So maybe if you think of clinicians or researchers trying to make sense of a complex data, complex patterns, or complex ideas, maybe ChatGPT or its versions is a good tool. For example, if we need to explain what Odyssey is, or if we need to summarize electronic health records, which is not possible now because of a PICHA, of course. But if you think about, for example, intuitive and easy to digest summarization of the health records, I would think that large language models could do well in that regard.
Yeah, no, that's actually what I was also thinking about is I just came across this yesterday. There's a tool that's built on top of ChatGPT that can read tables now. And given how prevalent tables are in publications and reports, and like you said, since language models they do very well in explaining things, can we maybe do a reverse, right? So we now write the report, we have a bunch of tables, and then ask it in reverse to describe what the machines and tables as a way to increase, I don't know, maybe efficiency in interpreting the results, or just getting back the results to the clinicians. And maybe that'll increase its adoption at the point of making the decision. So
yeah, that's a really great idea and a great point. And if you think about very practical use of it, if you remember, Martine built this tool/package that takes the output of her study and sort of fills the template of a clinical paper, the methods part, the results part. So what we are missing is the background and the discussion, right? So you can think of using large language models to produce some summary for the background, and then interpreting what you see in the tables and figures to place it in the discussion. So like having 80% of the paper already written for you.
Yeah, to me, like OMOP has the other side, right? It has a bunch of data, and then ChatGPT, like language models, is like having almost like an interface connecting you to the results and the more human readable interpretation. And like you said, if there's already a way to kind of map all the analysis and results to a structured kind of template, then you can also use that structured template to tell the language model where to look for certain information. And that's going to certainly increase, accuracy and sort of put outputs back. So I think there's maybe there's some synergies with Data Console. So we'll see.
Yeah, man, I do feel that we need to work more together on that. Because again, I already see that there are different labs working and trying to use ChatGPT for different tasks. So maybe we should start a new working group in Odyssey that focuses on large language models.
Yeah, and then also, right, because I think I came across this language model that was trained on PubMed articles and abstracts. I mean, can't we use that in conjunction with the data to maybe substitute some of the more simple and more, obvious diagnosis and decision-making processes? Because I mean, you have the literature and you have the data at your local institution. Maybe that can replace some of the more easier, more simple diagnosis problems. Very exciting. Thanks, Anna.
Sure, no, absolutely. I do feel that now we need a separate working group for that. It's going towards it. What I liked about this discussion is that it's been quite research oriented. I do not know necessarily, Faiza, if you get everything that you wanted from this conversation career-wise, but I pretty much liked the research orientation of it so far.
No, I think this is more than what I would have asked for. Thank you so much for sharing all of your insight. So I guess for people who didn't get a chance to attend this live, how can they contact you if they have more questions for you, or maybe want to get career advice because they want to go down the same path as you?
Yeah, of course. Or, work on some of the projects we've been working on. Absolutely. I mean, the easiest way is to shoot me an email or in Teams, right? You can look up people in Teams. If it's email, it's basically my last name at odyssey.org, which is quite convenient, right? But of course, Teams is the most easily accessible channel of communication. And I would be happy to answer questions or to work on something, collaborate. If you roll out mentor-mentee program, I would be happy to participate in that as well.
Yeah, well, I know at the last Odyssey Symposium and the European Symposium, we had a Meet the Mentors event. So maybe I'll reach out to you if you want to do it this year at the 2023. Awesome.
Absolutely, of course.
Thank you so much, Anna. I think that's everything I had. Did anyone else have any other questions before we wrap it up?
No, Anna, thank you so much, and thank you for all your leadership in our community.
Thank you, Anna.
We should do better, and we will do better.
There's
Thanks so much, Ben.
It is a great time for informatics and for evidence in medicine.
Yeah, and you're definitely leading it, Anna. You're at the forefront.
It's nice to hear that. I do not necessarily always feel like that, but it's nice to hear that.
All right. Take care, everyone. Thank you for coming today.
Thanks so much for inviting.